Good evening, all our colleagues from Maharashtra Ophthalmological Society, and especially our young stars, our postgraduates who are joining us today to learn the pearls of ocular surface this month. We all know that MOS is the largest state society of India and has been doing many academic activities, which are great initiatives for both postgraduates and all our members also. This year, we have decided to dedicate 1 month to one specialty. And for this month, the specialty is the ocular surface. Ocular surface is oftenly, probably in a way, let's say, underexposed specialty for most residency programs. And here we are very, very lucky to have some of the stalwarts, our national faculty, state faculties, mentors, who are going to take us through the postgraduate level understanding of ocular surface. And I'm sure that even for our other members who are practicing comprehensive ophthalmologist, this is going to be a great learning webinar as well. So, from the MOS team and as chairman of scientific committee, I'm happy to welcome you all, especially our national faculty, Dr. Vinit Joshi, our state faculty, Dr. Rohit Bang from Aurangabad. The mentors for today's webinars are Dr. Mayur Kulkarni and Dr. H.T. Karat sir. And this is going to be moderated by Dr. Shruti Varke. I'm as the team MOS, we are very thankful to Dr. Sumit Lahane for his untiring efforts in coordinating this webinars throughout the year. And now I would like to request our Honorable President, Dr. Santosh Agarwal sir, to please give his welcome address. Over to you, sir.
Thank you, Vardhaman. Dear colleagues and my dear friends, very good evening to one and all. And I welcome you to this unique webinar for PGs. But I suppose this is also meant for our members as well, because there are so many faculties or stalwarts who are going to discuss, and the tips and tricks, whatever are there, we can imbibe those tricks and tips, and we can use these take-home messages in our day-to-day practice. So I think this is also useful to our PGs who are going to appear for the practical exams, and how the viva is taken. That can be highlighted in this session. So that is useful for PGs also. So I request all the PGs to take part in these webinars and imbibe the knowledge and skills of your practical exams. Thank you to our team, MOS team, and especially Dr. Sumit Lahane, all the faculties, national faculty and our MOS faculty, all the participants and also PGs, and best of luck to their exams also. Thank you very much for giving me this opportunity. Over to Vardhaman, please.
Thank you so much, sir.
And last one quote for this day.
Yeah, that is what I was planning to remind you this time. Yes, we are looking forward to it.
Yeah. So today's my quote for everybody: speak positive words into your life every single morning. Think big, think healing, think success, think peace, think happiness, think growth mindset, and always start the day with positive energy. You deserve it. Thank you very much.
Thank you, sir. Very uplifting and positive quote. Amazing. Thank you so much. Yes. So now, without further ado, I would like to now hand over the course of this webinar to our chief coordinator, Dr. Sumit Lahane. Over to you, Sumit. Thank you.
Thank you, sir. Good evening, everyone. We would like to thank our MOS team who is helping us, all the postgraduates from all over the colleges, to participate on this state level, national level webinars and have experience in presentation. So we would like to thank Santosh sir, Atul sir, Vardhaman sir, Aditi ma'am for their untiring support in conducting these webinars. So today we have national faculty, Dr. Vinit Joshi. Vinit Joshi is a very good friend. He did his fellowship from LV Prasad Eye Institute. Presently, he is a consultant there. And also he is a clinician plus scientist. He is doing his PhD presently there, and he's very known national and international faculty. Thank you, Dr. Vinit, for being here and uh, being there on a single phone call in such a short notice. We are really grateful to you. We also have our own Dr. Rohit Bang sir, who is a senior consultant of cornea in Aurangabad, and he has his own center, Shri Krishna Netralaya. Sir is a master surgeon in his all lamellar keratoplasties, and thank you, sir, for being here.
Thank you. Thank you, Sumit.
Yeah, our mentors for today is Dr. H.T. Karat sir. Sir is a mentor to mentors. He is a teachers of teacher and is presently the professor HOD of MIMSR Medical College Latur. We also have Dr. Mayur Kulkarni sir, who is assistant professor presently at GMC Latur. Though he is a retina surgeon, we have kidnapped him for our ocular surface webinar today. Thank you for mentoring the session, Dr. Mayur. And of course, our heroes for today is Dr. Samruddhi and Dr. Komal, who are going to present their cases. And to moderate the whole session, we have Dr. Shruti Varke, who is a consultant at Vijana Institute at Pune. And thank you, Dr. Shruti, for being here. So I'll hand over to Dr. Shruti and Dr. Komal. Dr. Samruddhi will start the presentation. Shruti, please.
Good evening, all. Thank you, Sumit, and thank you, Mos, to have me here and give me this opportunity to be with all of you. So, without wasting the time, I'll hand it over to Samruddhi. Samruddhi, you can
Yes.
start your presentation, please.
Yes, ma'am. Good evening, ma'am. I'm thankful to Moss for giving me this opportunity of presenting. So I will share my screen now.
Make it full screen.
Yes, sir. Yes, sir. Just doing it, sir. Okay, good evening, one and all. I'm Dr. Samruddhi More, Junior Resident in Department of Ophthalmology in MIMSR Medical College, Latur. I thank Dr. H.T. Karat, sir, who has been my mentor for this presentation. So I will begin with my presentation, sir and ma'am.
Yes, please.
Please.
Okay. So I begin with my case. I came across a 58-year-old male farmer by occupation who came to our outpatient department with the chief complaints of soft and fleshy mass in left eye since 9 months and watering and redness of the same eye since last 9 months. Moving on to the history of his illness, patient was apparently all right 1 year back when he started noticing a soft fleshy mass which was encroaching onto the left eyeball from the nasal side. Initially it was small and gradually it increased in size till the current size. Patient even complained of watering from right eye since 9 months, which also has been increasing till date. Since last 2 months, patient is newly been complaining of left eye redness. The patient gives history of eye surgery for similar presentation 2 years ago and has now expressed his concern regarding the reoccurrence. Patient has no history of headache, mucopurulent discharge, chemical splash injury, burns, or ocular trauma. Past history is non-contributory. Personal history, patient has been a chronic smoker and tobacco chewer since last 20 years. Family history, a patient gave us the history that his father had similar conditions in both the eyes, which he never got really operated for. Moving on to the general examination, patient was conscious, cooperative, well-oriented, and the general condition was fair. BP and pulse were normal. Patient's systemic examination was also within normal limits. Moving on to the ocular examination, patient's vision in the right eye, I will begin with the right eye first. Vision in the right eye was 6.9, which went up to 6.6 on best correction. Extraocular movements were full, head posture, facial symmetry, eye alignment, and interpalpebral fissure were all within normal limit. Left eye vision was 6.12, which went on to 6.6 partial with best correction. Moving on to the slit lamp examination. Patient's right eye lid was normal. Conjunctiva in the right eye showed progressive triangular nasal pterygium. Cornea, pterygium was encroaching onto the cornea from 3 o'clock to 4 o'clock hours at limbus, and which extended 2 mm beyond the limbus. Anterior chamber, pupil, and lens in right eye were normal. Lens had early cataractous lens changes. The left eye examination, lid was normal. Conjunctiva of left eye had a thick, fleshy, progressive vascular nasal pterygium present. The dimensions of the pterygium were almost 3 mm into 4 mm. The cornea, pterygium had encroached onto cornea, presenting from 8 o'clock to 9 o'clock hours at the limbus. Corneal epithelium anterior to the pterygium showed Stocker's line, and patient even had old pterygium excision scar present onto the left cornea. The left eye anterior chamber pupil were normal, and the lens showed early cataractous changes. Color vision and intraocular pressure in both the eyes were normal. This is the clinical picture of my case. As per routine examination, dilated fundus examination was also performed for the patient, which was within normal limits. Hence, I move on to the diagnosis of the patient. So my patient is a case of left eye recurrent pterygium with early cataractous lens changes, while the right eye showed primary nasal pterygium with early cataractous changes. So I end my presentation. Thank you, sir and ma'am.
Thank you, Samruddhi. I would like to ask Dr. Mayur Kulkarni, sir, for further questions to our PGs.
Yeah. So nice presentation, Samruddhi. So I'd like to know some basic difference between the pterygium and pseudopterygium. Can you please elaborate on that?
Yes, sir. Sure, sir. So, pterygium is a proliferative growth of subconjunctival tissue which encroaches onto the cornea in a triangular fashion, while pseudopterygium is extension of bulbar conjunctival tissue onto the cornea, in which only the apex of the tissue has been adhered onto the cornea. The rest of the head and the body in pseudopterygium is not fixed to the eyeball, hence even a probe can be passed beneath it. And moving on to the etiology, pseudopterygium usually has a prior history of chemical injury or some ocular injury, which leads on to its presentation, while pterygium need not have any such history, as it is common due to in farmer occupation or in people who are more exposed to heat and UV radiations.
Okay. So, any further points do you want to add, Joshi sir or Rohit sir? For our PGs to understand more.
So, one thing which, first of all, thanks Sumit, and it's very nice to finally be a part of MOS sessions. And I am basically from Pune, so I have a lot of attachment to Maharashtra Ophthalmic Association. And this is a nice, very simple case, a short case, you can say. So, mostly, all points are well covered, but some things you need to add because you mentioned about recurrent pterygium in the left eye. Some leading history has to be asked regarding what was the type of surgery which was performed in the left eye. You can try and guess some clues based on examination. What technique was probably used? Was it bare sclera technique, or was any autograft used? And in such cases, you should always mention about what is the superior conjunctiva. So usually, or inferior, from wherever there are the chances that the graft might have been harvested. So you can always mention that these areas are normal or abnormal or something in that sort. Because you mentioned that it is recurrent pterygium and you're planning for a surgery in that case. So identifying the sites which are healthy for regrafting would be clinically relevant in this one.
Sure, sir. Yes, sir. Thank you so much, sir. Our points will be noted, sir.
Again, one more important point. Hello.
Hello.
Yes,
Hello.
sir. Yes, sir.
Yes, one more important point could be whether the patient is having any glaucomatous signs or something. Because if that is the scenario, then you might not be taking the graft, congenital autograft from the superior side, because you might have to preserve in case if blade is required in future or trabeculectomy is required in the future. In such cases, if at all patient has any glaucoma history or you anyway suspect that he might require a trabeculectomy or a bleb surgery in future, you might take a graft from the inferior conjunctiva rather than from the superior conjunctiva.
Yes, sir.
Samruddhi, please stop sharing your PPT, please.
Yes, ma'am.
Okay.
Usually these short cases get directed very quickly to plan of management and the way you will treat. And considering the age of the patient, it is very highly likely that you will be directed towards questions of combining pterygium with cataract surgery or combining the both or not combining the both, and what are the thought processes associated with both of them. So you should have a good clinical reasoning on both the sides, right? Not being biased to anyone, but having strong clinical explanation to each of them. I think that's where you will score the best of marks as to how clear are you on understanding what is the plan of management to go ahead with.
Yes, sir. Sure, sir.
Okay. I would like to ask the panelist that what are the tips you can give for the management of recurrent pterygium, and what is your take whether to use whether we are doing the regrafting, so whether to use AMG or what else tips you would like to add, sir?
So recurrent pterygium, as you right now mentioned two categories. One is normal pterygium and the other pseudopterygium, and you try to differentiate between two. Recurrent pterygium falls somewhere in between them. So basically, when you talk about pseudopterygium, you're talking about an actual focal limbal stem cell deficiency which has occurred on the ocular surface. As a result of that, an abnormal epithelium is growing and it is contiguous basically, and it is something that is not ever going to heal by itself, which you normally see in a pterygium case. So recurrent pterygium is somewhere in between that. So there is some amount of LSCD happening, probably because of the first procedure, if it was too extensively
Vigorously
operative
done.
or aggressive, and some techniques like Bear sclera techniques are very harmful. They really lead to highest rates of recurrent pterygiums. But the problem that happens with recurrent pterygium is that in the attempt of removing the same, you will incite more limbal stem cell loss. So usually in these cases, it's always good to do depend on the size. Now, if it is a smaller one, you can still get away with a good conjunctival autograft. You might include limbal autograft in that conjunctival limbal autograft, but usually in LVP we don't advocate any form of conjunctival limbal autograft for pterygiums, even for recurrent pterygiums. So the hypothesis there is that there are some nests of stem cells even in conjunctiva which help in kind of resurfacing the whole thing. So usually only in really large recurrent pterygiums like second, third attempt and more than 4 clock hours, where you know that this goes more in favor of LSCD and not just a small recurrent pterygium as it was in your case, you can still get away with the conjunctival autograft. And now if you are limited in getting access to good quality of conjunctival autograft, suppose they have done autograft before and now there is fibrosis inferiorly, and as sir mentioned, if the patient is has glaucomatous optic disc and you can't touch the superior conjunctiva, so you might have to take a smaller graft from inferiorly. So you take a small graft, pair it with AMG, so you remove the recurrent pterygium place the conjunctival autograft nasally, and in the remaining area you cover that with AMG. So you can do these two things too. So that will decrease your need for conjunctival autograft harvesting and also use amniotic membrane. In other cases, you can just get away with a simple conjunctival autograft done properly. And the key here is to get rid of all of this damaged subconjunctival degenerated tissue. That is the real culprit. If that is not removed, if you leave any remnants there, they are going to grow back.
Okay. And is there any role of combining slit with the graft in big pterygium, maybe like involving more than 4 to 5 clock hours?
So I can give you some examples, not for these kind of recurrent pterygiums, but
Yeah.
especially
Post
in cases
injury.
where we do. So whenever there is LSCD secondary to OSSN, where we treat ocular surface neoplasia with chemotherapy.
Right.
Usually these chemotherapies we use 5-fluorouracil. So what happens here is very like offset LSCD, which is focal, and it leads to kind of a pseudo pterygium kind, but it's very dense. It's very so you know that this is not going to heal by itself. In those cases, a mini slit really helps. There is a case series where we have
Mhm.
done this. We have combined mini slit with this OSSN post OSSN cases. Mini
Okay.
slit with AMG and
AMG.
autograft, it works well.
Actually, what I would add is like even if they said 60 to 70% your limbus stem cells are there, that should be sufficient enough. So there's a localized LSCD in the cases of a recurrent pterygium, but given the fact that rest of your limbus is okay, should compensate. So just doing as Dr. Vineet said, for even for recurrent pterygium, just doing a very nice autograph. What we need to know is a primary pterygium, it's a fibroelastotic degeneration. And recurrent pterygium, it's more of a fibrovascular proliferation. So in a recurrent pterygium, it's more of a vascularization and it comes up in a little aggressive way. So in the best of the hands or whatever we are practicing, even mitomycin C or something is not required actually. That causes more damage at times if a proper wash is not given and some sort of scleral melting that we had seen. But rather, if we just do a proper dissection and removing all the subconjunctival tissue and putting in a nice big autograft, that really helps with a lot of steroids in the post-op regime, some sort of a good amount of lubricants, that really helps. So generally, we say that in a bare sclera, there was the highest incidence of recurrences, followed by the AMG, and then with a conjunctival autograft, at least in a primary pterygium, I would say that even 99% of the cases, there is no recurrence if done properly, at least in a primary pterygiums.
Thank you, sir. Samruddhi, can you just elaborate what is the concentration of MMC we use for recurrent pterygium cases?
Yes, ma'am. Sure, ma'am. Ma'am, MMC can be used at 3 stages: pre-operatively, operatively, and even post-operatively. Like there have been trials where pre-operatively MMC has been used. So in pre-operative, there is injection of 0.15 mg per ml into the pterygium 1 month before the surgery.
Mhm.
And then for 1 month, patient had been followed up in the trials, and they had noted the regression of pterygiums. While if it is used on table intra-op, then 0.02% is used, like application has been used for almost like 2 to 5 minutes on table, depending on the size of the pterygium or the type of growth, whether it's primary or whether it's recurrent. So depending on that, 0.02% of mitomycin C can be applied. And there have been trials where even post-operatively mitomycin C as eye drops in percentage of 0.02% have been used as dosage of BD for about 5 to 10 days, ma'am.
So, just as a PG, it is a PG forum. So, what extra advice whenever you are prescribing MMC drops to the patient? What precautions you'll ask patient to take?
See, mitomycin C has mitomycin C has complications of dry eye, Dellens, then conjunctival scarring or fibrosis. So after the usage, if patient is feeling discomfort or like increased of redness of eye, watering, I think he should urgently report back to us.
Okay, always whenever you are prescribing mitomycin to the patient, yes, of course, you have to tell them that these are the symptoms they might have to irritation and dryness. So you always give lubricating eye drops with that. Never give only mitomycin. Okay.
Right.
Another thing, it induces dryness definitely. So there has been cases that we might have to put some punctal plugs in some patients because we don't want systemic absorption of the mitomycin as well. Okay.
Yes.
I think that's enough for PGs.
Thank you so much, ma'am.
Yeah.
Thank you.
So, Komal, are you there?
Yes, ma'am.
Yeah. So, please go ahead with your presentation so we can have discussion on your case as well. Thank you, Samruddhi.
Thank you so much, ma'am. Thank you.
Yeah, until she loads the presentation, one important side effect with mitomycin C is the long-term scleral necrosis that happens. So that is something PGs you can keep in mind. So the most detrimental complication of pterygium surgery is where you will end up with a scleral melt and something with a necrosis. So you can read about what is SINS, SINS. That's a very interesting topic. The examiner can guide you there slowly, and the treatment of that is very different. You're entering into a different area altogether from surface to sclera and connective tissue diseases.
Please start.
Good evening, one and all. I, Dr. Komal Godse, third year junior resident from VDGM Silatur. I'm going to present a case of total limbal stem cell deficiency. I would like to thank Dr. Uday Mohite sir and Dr. Michael Kani sir for mentoring, and I would like to thank everyone for giving me such an opportunity. Shall I begin with this?
Yes, please. Go ahead.
Yes. A 10 years old male child brought by parents to ophthalmology OPD with chief complaints of diminution of vision and foreign body sensation in left eye since 2 years. On detailed examination, patient was apparently all right 2 years back when he had an accidental lime exposure to the left eye, after which patient started complaining of diminution of vision, which was sudden in onset, painful, progressive in nature. It was associated with foreign body sensation, watering, redness, and photophobia. He underwent local ophthalmological consultant, where eye wash was given and he was prescribed some eye drops, details of which are not available. He visited multiple times to local hospital for ocular discomfort and was given treatment for the same, but his symptoms did not relieve. Then he visited our OPD. There is no history of contact lens uses, itching, rubbing, or allergies, no history of past ocular diseases or any past ocular surgeries and any systemic illnesses. Personal history and family history was not significant. In general examination, general conditions, afebrile, pulse rate 80 per minute, respiratory rate was 20 per minute, blood pressure was 130 by 90 mm of Hg, saturation was 99%, systemic examination was within normal limit. Moving towards the ocular examination, head posture of patient was normal. There is no chin elevation. Extraocular movements of the right eye was within normal limit, and in left eye, there is restricted in superior gazes. First, I would like talk about the right eye findings. Best visual acuity of right eye was 6 by 6. Anterior segment and posterior segment of right eye was within normal limit. Moving towards the left eye findings, best corrected visual acuity, perception of light and projection of rays was accurate. Eyebrow, eyelid, eyelashes was normal. Conjunctiva shows symblepharon at 10 o'clock to 2 o'clock position. Upper forenasal contraction was there. Corneal surface was irregular. Total conjunctivalization of cornea and fibroscular panis was present. Posterior segment. Anterior chamber, iris, pupil details could not be assessed due to the 360-degree conjunctivalization of the cornea. Lens details also could not be assessed. And fundus examination by indirect ophthalmoscopy. Right eye shows disc normal in size and shape. Cup disc ratio was 0.3 to 0.4. Foveal reflex was present. Periphery was normal. Left eye fundus could not be assessed due to 360-degree conjunctivalization of the cornea. This is the clinical picture of left eye of patient showing multiple findings. There is 360-degree conjunctivalization of the cornea. Fibroscular pannus was present. Upper forenasal contraction was there. And also symblepharon was present at 10 to 2 o'clock position. Moving toward the provisional diagnosis. My patient is diagnosed as a right eye was within normal limit, while left eye shows total limbal stem cell deficiency secondary to the chemical injury. Thank you so much.
Thank you, Kamal. Nice presentation. I would like to ask Dr. Mayur Kulkarni. Please, sir.
Yeah, nice presentation, Dr. Komal. I would like
Thank
to
you.
know, yeah, what are the grades of the chemical injury? If you can elaborate on that.
Sure, sir. There are two grades of chemical injuries. First one is Roper and Hall grading, and second one is Duas grading. In Roper and Hall grading, there are 4 gradings based on ocular surface injuries and limbal ischemia. In grade 1, there is ocular surface injury with the corneal epithelial defect having a good prognosis, and there is no limbal ischemia. In grade 2, ocular surface injury with stromal haze having good prognosis, but there is till 1/3 of limbal ischemia. In grade 3, ocular surface injury, stromal haze, iris details are not visible. Prognosis is guarded prognosis, and limbal ischemia is from 1/3 to 1/2 of involvement. In grade 4, ocular surface injury involving stromal haze, iris and pupil details are not visible, having a poor prognosis, and limbal ischemia is up to 1/2. In Dua's classification, there are 6 grades in which limbal involvement is compared to the clock hours. In grade 1, there is a 0 clock hour involvement of limbus. In grade 2, till the 3 clock hours of limbal involvement. In grade 3, 3 to 6 clock hour involvement. In grade 4, 6 to 9 clock hour limbal involvement. In grade 5, 9 to 12 clock hours in grade 4, 6 to 9 clock hour limbal involvement. In grade 5, 9 to 12 clock hour limbal involvement, and grade 6 up to 12 clock hour involvement. So the initial 3 grades having good prognosis, 4th grade having guarded prognosis, 5th grade have poor prognosis, and 6th one have very poor prognosis. Also in this grading, conjunctival involvement is also mentioned.
Komal, can you stop sharing your screen? Mayur sir, you can go ahead with your questions since Karat sir is
So
not
basically,
for both.
yeah, this patient, which injury he had, whether it was alkali or it was acid?
Sir, patient has a injury by lime. Lime is a alkali, and it's a most common alkali causing ocular injuries.
And which is more serious, whether the acidic one or alkaline one?
So alkaline causes the more serious ocular injuries. Due to alkalis have more penetration power than the acids. Alkali acts, cation ions of the alkali acts by reacting with carboxyl group of collagen and glycosome and glycone. It causes saponification and hydration of the stromal tissue. Due to hydration of collagen fibrils, it causes thickening and shortening of collagen fibrils. which also distorts the function of trabecular meshwork and causes release of prostaglandins, which is most common cause of immediate raise in intraocular pressure. Also, alkali alters the pH of aqueous humor. So it causes the damage to ciliary body and causes acute inflammatory reactions. There is release of pro-inflammatory agents, proteolytic agents, chemokines, leukotrienes, which leads to epithelial corneal defects, corneal thinning, ulceration, and eventually perforation of the cornea.
So, Vinny sir, would
Deeper
you like
injuries
to
may
add
cause
anything?
stromal scarring. Sorry, sir? Not audible, sir.
Vinith sir, Rohit sir, you want to elaborate something?
Yeah. So very nicely presented, Dr. Komal. Really
Thank
nicely.
you, sir.
What was the time duration of the injury and presentation?
Patient had an injury 2 years back.
2 years back, yeah. And
Yes, sir.
so here, what is important is when in the history, what you can include is you can add what was the preliminary care that they could take at the time of burn, whether they did or they did not, because still majority of the people do not understand its severity, because they'll just wash and they'll just ignore many times. But as you said, this is tuna burn, and in tuna injuries, the residual particles tend to be in the ocular surface for a very long time. Even a small one hidden anywhere can cause a lot of problem. So maybe a history on that part will help, where you can ask about what they did initially, and if any surgical procedure was done, that really helps at this point of time. As a clinician, that will help you a lot to plan the next course of management, basically. So if at all someone has done an amniotic membrane graft at that time initially, so it helps you to understand that, okay, now if I am going to do a surgery in this one, so I will have an easier what do you say, an easier access to the corneal surface, that the pannus will come off very easily because you did an earlier amniotic membrane graft. So it can make things easier for you in this procedure. Second clinical points that you can add here is fluorescein staining is very important in all ocular surface cases. So if you get a chance, you should always specifically mention about fluorescein staining and mention what is the type of staining. So typically conjunctival epithelium stains differently than corneal epithelium. So you can highlight those points, that whether it was what type of staining, is it conjunctival epithelial pannus or what kind it is. Then you mentioned about fornitional foreshortening and symblepharon formation. So they will ask you about differences between the grades of symblepharon that can happen. Now, what is very important in your case that the examiner will definitely ask is, why is there symblepharon superiorly and not inferiorly? So this is very important because most common site of lodging of lime in a lime burn is superior fornix, because that's why we always advise to double evert the lids and actually remove the residual tuna out. That's where it stays for a long time. As you mentioned beautifully, all the chemical reaction, it keeps on causing that exothermic reaction superiorly. That whole collagen of subconjunctival tissue, tenons, everything becomes fibrotic, charred like a lesion, and it forms that symblepharon superiorly. And because it's an exothermic reaction, it destroys the limbal stem cells totally. So it causes a very bad symblepharon in that particular region. In fact, even after 2 years, if you try to explore this region, you will find calcified plaques of lime inside this when you open this up. These clinical points will help. And where they will ask you more questions is the initial treatment in these lime burns, what you should do, how frequently you should give the wash, and then how you will test while giving the wash with litmus paper, you can do that so that you know that the pH is going down. And then after washing, what are the earliest remedies that you can do? What is the treatment in acute chemical burns that you can give to prevent a picture like this? So questions can come in that way. And if you want to talk about management in this case, I mean, we can discuss about that. I mean, if you want to ask that as a separate question, but this will be a not a single stage procedure. You should always tell the patient they will need multiple surgeries. It will be a phased procedure, and initially, then they will ask you about what would be the ideal circumstance, situation for this patient, which is his unilateral burn, which is a perfect situation because the right eye is normal, so they have good limbal stem cell nest there. So slit can really work in these situations, but not just alone slit. There is a lot of accessory procedures that you will have to do along with it, which is basically you can never do slit in a case with simlifron. So first you have to get rid of the simlifron, and the best way to get rid of simlifron is to do a conjunctival autograft. So that also you have to harvest from the other eye because this eye doesn't seem to have any healthy tissue left. So conjunctival autograft with slit can work in this case. So that could be your first line of management at this point of time.
The most important thing is, as Dr. Vineet said, any sort of chemical, this tuna has to be removed. So you need examination under anesthesia or any sort of a sedation if it's a kid or something. And double eversion of lead is the most important thing that examiner is very happy to listen, because any sort of foreign body left in the eye is going to incite an inflammation, and that is the crux that will lead to a simple formation. Again, the older examiners would be very happy to listen. What is your say on conjunctival limbal autograft and slit? Whether a conjunctival limbal autograft works equally well, or you would be doing a slit. So if it's a localized area, as in a case of a recurrent pterygium or multiple surgeries, CLAU might also be equally good. But then in case there is extensive limbal stem cell loss, the slit gives a better results, because you can harvest a minimal amount of limbal tissue and you can spread it all over the surface. And you need to know the pit pat, all the steps of a simple limbal epithelial transplant. And if you're able to say that, your Viva would go further in ocular surface, like as the Dr. Vineet was saying about the stages of a simplifron. And also in the previous cases, what has been the grades of a pterygium, like what is the grade 1, depending on the encroachment of pterygium on the cornea. That are also very important points that old style, if you get exams for a DNB in a government centers, you're very likely to be asked what are the chances of recurrences in a bare sclera, in a amniotic membrane, and in a conjunctival autograft. And so, like you said in the previous case, that you're going to give a intra conjunctival, the pterygium MMC. I think that is not being practiced nowadays, at least in a best of the centers, because that leads to a very troublesome scleral necrosis, and you might end up with needing a scleral graft and devastating complications. So intra pterygium MMC is not being advised or not being practiced.
Thank you,
Thank you so
sir.
much, sir. I'll note down all the points.
Yes.
Taking ahead on the same lines, little few questions on the management. So we were all talking about the slit. So what would be ideal time to do slit? That is one part of the question. Secondly, as acute management, the most important thing that we give to this patient is topical steroids. So another question, that how long we should continue topical steroids in this patients? Rohit sir and then Vinit on the same.
See, like in a peripheral centers or a general ophthalmologist or anyone, like the first treatment in a chemical injury is a thorough eye wash. Even if you don't have those litmus strips or something, you give a eye wash. If you don't have a NS, you just give it with the tap water. But lot of eye wash, and very important thing is a double immersion of the lids if it's possible, and it's not something very difficult. So once that is done, then question being asked in government centers is in a presence of an epithelial defect, whether you would immediately start up with the topical steroids. So even if the BCL is not available and the peripheral centers or something, sitting in an institute like I'd seen at SN or maybe Ganpati or in a like tertiary care center, BCL might be available. But in lot of general ophthalmologists, even taluka places, BCL might not be available. So still you can start up with the topical steroids and then refer the patient to the higher centers. And as far as when to do the slit, it's the slit has to be done only once the eye is totally quietened, because otherwise if there is a lot of inflammation, your amniotic membrane would get absorbed immediately and the whole purpose might not be served. So the eye has to be quiet, and only then you can take up the patient, maybe at least 6 weeks or something after the initial insult that has been done by chemical injury. You can think of getting a slit done if there is a extensive limbal stem cell loss.
Vinit, your take on the same?
So, for steroids, so you can see steroids in a way that they are very essential to kind of release the limbal stem cells from a state of shock. So, what we are trying to do with steroids is trying to save as much as stem cells as possible after that initial insult from the chemical. And this is one indication in cornea where size of epi defect doesn't matter, but you go in with hourly steroids, it doesn't matter. It is a rescue for the stem cells to save whatever population of stem cells, limbal stem cells possible. It can be saved with steroids. Now here comes the real trick is for how long to give. So as she was mentioning about the grades or the clock hours of limbal insult, it is based on that what it actually determines how long to give topical steroids. So basically, if the burn is just involving 3 clock hours, flow 4 clock hours, you know that the remaining rest of limbus is still fine. So at some point of time, you are buying time with steroids so that you help the normal cells to come out of a state of shock so that they start producing normal corneal epithelium. And sometimes it takes 2 weeks, sometimes it takes 3 weeks, sometimes it might take a month. So the idea is to give topical steroids hourly, then decrease it slowly to 2 hourly and maybe 3 hourly by 1 month. But give them that high dose of steroids to rescue these cells and monitor this by seeing staining the patient at every visit, a fluorescein staining to see if the epithelial defect is resolving or not. So this really helps. And sometimes, as you mentioned, if it's a grade 3 burn, like in these patients, it might not even take up the fluorescein stain because there are no tears. It's a complete bare like exposure of corneal stroma. In such cases, you don't expect any improvement. So what happens in these cases, you give them topical steroids for the overall ocular surface inflammation to quieten down, as Rohit sir was mentioning. And we should have clear idea what are the outcomes that we are going to face. One, if the limbal stem cells do well, it will form a corneal epithelium or a kind of a pannus, which is not entirely a conjunctival epithelium. Two, if it is LSCD, the conjunctival epithelium is going to grow in completely altogether. So basically you allow this to happen fast with steroids. Either corneal epithelium comes in or you allow the conjunctival epithelium to come in. And once this whole process is done, this is a natural healing process of the ocular surface and eye. Once this is done, once everything becomes quiet, you plan for slit. So that's the first ideal time to go for slit. Now, how the outcomes? Yeah, tell me, Smith.
Yeah, no. Thank, I got the answer. One last question on this forum on this for this case, for the benefit of the PGs, Vinit, can you tell options of management of bilateral LSCD? This is a case of unilateral, but they might be asked that what is the treatment option for bilateral LSCD? Can you just give a simple answer for that so they can answer in the exam and I understand as well?
Bilateral LSCD, if it is like as severe as, or we can just say that bilateral LSD, one eye is total LSD, other is partial LSD, then you can take a closed call on whether autologous slit might help or something, but you should avoid doing that. In such cases, cadaveric alloslates can help. Cadaveric alloslates are a better option. They can, to some extent, help rescue the ocular surface, but it has to be accompanied with, like as I mentioned, simplifron release, conjunctal autographs, and a tarsorrhaphy would be very much needed in these cases. And then you have to keep the patients on for systemic immunosuppressants like oral steroids or maybe cyclosporin or something, because to protect these explants of alloslet. The last resort could be keratoprosthesis. That's one thing that you can do in one of the eye. So usually you keep one eye as a reserve, and you can go for keratoprosthesis in one eye or the severe eye with severe disease to rehabilitate the vision. So these methods can work. You can combine K-Pro with Alloslate in the other eye, or you can mix and match these things. Sometimes you can also use the serum drops to help improve the ocular surface. So basically, you have to keep trying a combination of things based on case-based scenarios. As Rohit sir was mentioning about that conjunctival limbal allografts, in some cases you might even not in bilateral cases, but in some unilateral cases previously they used to do keratolimbal allografts. So that also they have tried. But in bilateral cases, you really don't have much options other than alloslates and keratoprosthesis. Now there is something new which has come, which Dr. Sanbasu is trying. It's called as SOMET. So basically, they are taking buccal mucosa, and they are explanting it as slit. So just previously they used to do mucous membrane grafts. So now they are using those as limbal explants, basically like stem cell explants. So like how clet became slit. So now there is one SOMET. So that's new thing is coming up.
So thank you for the wonderful discussion. Now we'll go back to Dr. Shruti. Um, you are ready? Yeah. So she has two simple cases of presentation, and on that we will have a forum discussion that how do you manage those cases, and shoot takeaway points from that for our all the ophthalmologists and PGs. Shruti, you can
Yeah,
share.
I'll start. Is it visible?
Yeah. Rohit sir. Okay, I think you can make a full screen and go
Yeah.
ahead.
So the first case, that's 27-year-old female. She came with the basically complaint of diminution of vision in the both eyes, but left eye more than right eye, and redness and irritation in both eyes since almost 5 years. And there is a history of on and off medications for red eye since childhood. So she states that there is a history of allergy. Her eye has allergy reaction since childhood, and she also states that there is she was used to rub the eyes quite a lot. So simply there is a chronic eye allergy since almost 15 years, and apparently she was using scleral contact lenses since last 3 years. So this is the clinical picture. So it's the both this is right eye and left eye. So here we can see the scleral contact lenses are on, and there are deep and superficial vascularization of almost upper half of the cornea. In the right eye, pupillary area is not involved completely, but in the left eye, now it is involving pupil area with the scarring and opacity adjunct to it. So maybe because of that, her vision in the left eye has decreased. So she is on and off on low dose steroids sometimes, and sometimes somebody has given cyclosporine, but she was not using it regularly as prescribed. So my question to all the panelists and all the stalwarts, that how to manage this case, whether we use a cyclosporine and steroids, how long, or any role of anti-VEGF for regulating that new vascularization, or whether she should stop using lenses because she is quite has got a cylindrical power plus very irregular cornea. So normal glasses, her vision is not good with the glasses. With only scleral contact lenses, she achieves apparently good vision. She is an IT professional and she needs a good vision for her daily routine. And whether we can do the superior conjunctival resection and plan some slate, but what else we can do, and how to comfort, how to reduce her symptoms, visual. Hello?
Rohit sir?
Yes.
Rohit sir? Yeah.
You
Dr.
start.
Vinay?
My first, see, whatever said and done, as you are saying, the contact lenses is the offending agent. So she will have to be like off the contact lenses for some time. And we might have to continue topical steroids for a little longer time and taper it very gradually. But I don't think there's any role of a like anti-VEGF in such cases, because it reduces the angiogenesis, but whatever the vessels are already formed might not suppress with anti-VEGF.
She
So
actually, oh, sorry.
Yes.
She actually states that this vascularization was less before, and now it has increased. She
Okay.
doesn't have any old photographs or any records. Unfortunately, I don't have, but she said that vision has reduced since the last 6 months in the left eye. So my thinking was that the central neovascularization has increased in the left eye, at least because it started involving the pupil now. She never had
Right.
visual complaints. She was very comfortable with scleral lenses.
But then she's using lenses even now, like when she has reported to you?
Yeah, I asked her to stop, and I started her on steroid. But then I want to know like how long we should start when we continue the steroids. And being she's very young, I don't know how steroids will. I mean, maybe if she is steroid responder, then we might have
See,
to.
surface acting or soft steroids, what we call FMA, fluoromethanol, any sort of, might not have much of an intraocular penetration, and it might give us a very good results. And keeping a watch on intraocular, nothing works like steroids, as has been said. So if the only issue with us is raised IOP. So, but then if we continue it in a tapering fashion and maybe at least once a day, as in our graft cases or something, we continue it for almost like 6 months or 1 year also.
Okay.
So surface lubricants and topical steroids, we can continue for some time. And first thing, she, as I told initially, she has to be off the contact lenses, and then we can take assess the situation again. But a lot of times those vessels, they do regress once the offending agent is removed, and with surface topical acting or surface acting steroids, it does really help. And if the visual axis is clear or vessels regress, then we can think of any sort of a further treatment. Like if we have a regular astigmatism, we can think of even in case of astigmatism like ICL or something, if the visual axis is clear.
But anything can we do, sir, for this neovascularization, or I don't know, the diathermy works or not? I really don't. The
Diathermy,
feeder
you're
vessel
going to do the
at
bigger
conjunctival.
vessels, near the vessels, you can go and do the diathermy. So it will definitely shrink vessels to an extent. We can actually, like in a cases where we are doing a grafting or something, the bigger vessels, we actually go deeper and cauterize the vessels at least a week or 10 days prior or 1 month prior to your scheduled surgery. So to remove the offending, the blood vessels that are reaching the cornea. So in this scenario also, we can do a diathermy, but that would be near the limbus, and that would be only to the bigger vessels.
The feeder one, a feeder vessel of that.
Yes,
Okay.
yes.
So, Rohit sir, getting to the point in this case, basically we wanted to highlight the management of SLK, superior limbic keratoconjunctivitis, for all the general ophthalm and PGH. So
Right.
if you can just describe the same for our all ophthalmologists who are attending the meeting, it will be grateful, sir.
See, if you are thinking of SLKC, first and foremost, she's a female, right?
Yes, sir.
Yes.
27.
So get a workup done. There is a very high association of a thyroid also. So if that is there, then we need to treat her like we need to manage her thyroid profile. We can definitely start the contact lenses. She has to be off. Topical steroids, lubricants, and topical steroids. I would say we continue it for a very long time. Maybe even if the inflammation is less or something, we can continue it for at least 3 months, once a day, and then taper it further, maybe alternate day or something. Can continue on topical lubricants, and if the systemic workup is then normal, she should subside with this treatment. But I don't think any actually role of going and excising those pannus immediately. If the eye is quiet for very pretty long time, your systemic workup is also completely normal, then you can at least think of attempting a pannus removal and putting in an amniotic membrane graft.
Sir, any role of cyclosporine? If
Cyclosporine, once the eye is quietened, then we can think of putting her on a cyclosporine.
so, whenever we stop steroid and we can shift her to cyclosporine, or
Even once the steroids, it comes to a, like in a tapering fashion, once a day or something, and eye is really quiet or something, you can keep the steroids to a very minimal dose and put her on a cyclosporine at least twice or thrice a day.
Okay, sir. Dr. Vinit, sir, your
Yeah, I think steroids is the best line of management here. That should be the first line of management for any flare-up of superior limbic keratoconjunctivitis. What you can see in this case is those small white dots in between those blood vessels. That is typical flaring of inflammation. And usually they will respond very well to steroids. You can even give prednisolone 1 month and then shift to lotipred. Continue lotipred for a long time on a low dose, 2 times a day, maybe for 1 or 2 months, and then bring it down to 1 time a day for 2 to 3 months and continue it alternately.
okay.
Now, I don't know why scleral contact lens is given here. Is it only for vision or is the other ocular surface also equally poor? But usually in these inflamed states, you need to cut down the friction of the upper lid and the loose conjunctiva, which is in the upper fornix. That is where the problem is. So there is an excess conjunctival tissue, which is very which is very loose, hypotonic, and with every blink, it tends to fold onto itself and it keeps on rubbing. So that part, if that friction part, if you can take care of with a simple bandage contact lens and then give them a course of steroids, they might improve very fast. So that maybe you can try. For those blood vessels, you don't have to worry too much. Even in some ocular surface, very worst cases like Stephen Johnson syndrome, they will have a lot of blood vessels, but they will see very clearly with scleral contact lenses also. So vessels which are leaky are a big problem, which happens in HSV keratitis. They leak out a lot of lipid and it causes lipid keratopathy. There, subconjunctival Avastin works. It can work. And as sir mentioned, diathermy is just a 3 weeks therapy. The vessels come back again. So you might be very happy on table, but the patient comes back with the blood vessel in the same place again after some time. So not that effective. There are some case reports of trying something called as MICE, which is intra-arterial
Arterial.
injection of mitomycin. That also we've tried. It works, but it's very difficult to cannulate.
Yeah, it's such a small vessels.
So steroids, BCL, best.
And no contact lenses, I think. She is very, I tried to explain her, but her vision is good only with the scleral contact lenses. So that's why she's very reluctant to stop using contact lenses.
Maybe that is the culprit. You never know.
Yeah,
So
even
try her giving bandage contact lenses. Give good lubricants and steroid cover. She will definitely improve. And after that, you can look into if what contact lens can help her in that way.
okay. Thank you. Thank you. So I'll move on to the other case. This is basically a 22-year female, and she's a medical student basically, and she had history of some conjunctivitis 3 months back, and she didn't take the proper treatment because it consists of steroid. So she thought that steroids will cause some damage to her eye, and that's why she didn't use the drops as advised by doctor. And this is the picture. She came with this picture after almost 2.5 months of the first episode of the conjunctivitis. So this is typically of adenoviral conjunctivitis subepithelial. Now her vision, she has a lot of issue in her mostly left eye because of light scattering and halos, and she complains my vision has decreased. So my, again, this is a staining, a fluorescent staining picture of the same eye, the left eye. So in such cases, what to be done for such patients to reduce the symptoms, and what else we can try, because steroids will help to reduce this scarring and the opacities which are formed already, or any, and how long we should give the steroids, plus if we want to plan any laser procedure, PTK or something, because she's a high myop also. So at what time we should plan this laser treatment, or whether not to plan, and how to manage such cases, basically manage the symptoms.
Yes. So in this case is where your cyclosporin will be very effective. But again, in these case, in acute settings, low dose steroids really help. Doesn't matter for how long, but they will not actually reverse the scarring, but they will at least prevent worsening of the same. And you can give again a slow taper of lotiprate. Typically, what happens in these cases is patients stop these low dose steroids quickly, and then these actual subepithelial scars, they increase in size. Now, to contain them in that wherever they are, you can still get away with a good vision if you maintain them on a low dose steroid for 4 to 6 months. It really works. Give them 2 times a day for a few months, and as I mentioned, then bring down to 1 time a day at bedtime, and then give alternate day. Don't stop it; just let it be around there. And same time, you start either cyclosporin or tacrolimus. Tacrolimus ointment really helps in these cases, kind of maintains that effect for a longer period of time, and mostly they get away very well. The advantage of keeping them for 6 months is that you will see the behavioral pattern of the patient also, and also the waxing waning pattern of the lesions. So you will understand what is not working, is the patient is not working or the treatment is not working. So either which ways, it buys you time to until you take a call on doing a PTK or something. So that should be your last resort.
Yeah.
They do very well with these medications alone.
And so after 6 months, or maybe 6 months, we can plan PTK. And so whenever we are planning PTK or any laser procedure, do we have to start them on any antivirals? Is there any role of antivirals pre-op, starting antivirals, topical?
Oral, actually.
Oral also.
Yeah,
Okay.
I mean, it's mentioned in AO guidelines that one of the indications is basically when you are anticipating any form of viral recurrence after any laser procedure, you should give systemic antivirals actually. So yeah, it does work. Again, PTK works. It depends on the depth of the lesion, but it can, once the lesion is stabilized, then you do PTK, because till that time you can get away with medications.
Okay.
I would. Hello.
Yes, sir.
Yes, PT, but any this sort of scars, they are very highly notorious for recurrences. Even otherwise, also they have got a very high tendency. And I would say that you need to keep a very long-term quiescence. And as Dr. Vinit said, basically you look at the patient's behavior, how compliant the patient is, and any sort of a scar, long-standing scar, even if like I'm seeing a patient who had a scar very long back, eye is quiet or something, and I'm doing some procedure whether it's a cataract or whether it's a surface procedure like a PTK, it's better to start up with a oral Valsivir or oral antivirals. If not beneficial, at least it's definitely not going to be harmful. But a lot of times you see that you do some sort of a you do a grafting for a viral keratitis. After 2 years, you do a phacoemulsive cataract for him, and if by chance you forget to start on antivirals, he is likely to present you back with some sort of a viral keratitis. So same thing applies for even these scars also. Try to maintain the quiescent stage at least for 6 months to 2 years, I would say. Don't touch the eye. And if you are the patient is very motivated and so is the surgeon, you can definitely do that. You got very good results in the initial stages. But better to keep the patient on a oral antivirals for pretty long time again, at least 500 milligram OD for quite a long time, maybe at least a 1.5 months or 2 months also.
Okay.
The only thing is cost becomes an issue.
So, Shruti, just to add to the point what our panelists have said, that in such case, very important is that you can image them on doing ASOCT. There is very nice photo essay by Dr. Gokhale sir in the IGO itself, where he says that this active SPKs can be very well seen as subepithelial lesions on your ASOCT, and that is the time when they are active and your steroid, cyclosporine, tacrolimus, everything will work in that phase. Over a period of time, as you keep on imaging, you will realize that they are getting faded, and your ASOCT will show a picture where they are almost merged with your Bowman's membrane and they appear very irregular. At that time, there is very less chance of recurrence, and that is the time when you can stop the steroids, as they are not going to be active and the steroids are not going to work. So using your OCT tool for cornea in this stage is very useful to guide your own treatment. So all SPKs you can very well image on which are not getting treated with your steroids, or you want to know when to stop, the ASOCT will be very helpful.
Okay, thank you.
Great. Yeah. In fact, this ASOCT point I forgot to mention, very important in SLED cases also. It's very important tool in any chemical injury case, because it gives you an idea of endothelium which we tend to ignore in all these complex burns. And usually that is the seat of maximum inflammatory damage in most of the cases. So ASOCT is very important tool in most of these.
In fact, in the cases of OSSN, it is one of the diagnostic. If you are confusing between any sort of other lesion and OSSN, it gives you a very nice linear reflective image in a ASOCT, which could be diagnostic for OSSN. So ASOCT, yes, it's a very good investigative modality.
Also helps you to explain the patient better. It's very easier to show them on the ASOCT that why you are giving steroids now, because it's very similar to HSV, immune stromal keratitis, and the scarring. Like you can show them the swelling, the edema, and that's why you are giving steroids.
Thank you. Another thing I just wanted to ask, when there is an active inflammation, when patient comes into active conjunctivitis phase, is there any role of povidone iodine irrigation or drops in active when there is a chemosis or some pseudomembrane formation, if in some cases? So do you practice this? Because I know it's a old
school of thought.
Yeah, but does it really help practically or clinically?
We haven't tried it. I mean, they might have before, but we don't do it now. But there are some case reports that there is some benefit, but again, there is no limit to which how much to use and when to not use. So whenever that answer is not clear, I think it should be little careful.
Yeah. Thank you.
Thank you, Shruti, and thank you, Rohit sir, Vinit sir. Atul sir, you're there?
Yeah, I am here. Yes.
We are here at the end of webinar, and I hand it over to you for the official vote of thanks.
Sumit, any question from the on the chat box, or have you seen any?
I haven't received any today, sir.
Okay. No.
Yeah. Good evening, all members and the PG students here. We have a nice discussion today on ocular surface, as Vardhaman said, the much neglected topic here. And thank you so much, the National Faculty, Dr. Vinit Joshi, for the last minute acceptance of our invitation. Dr. Sagwan sir, because of his ill health, not able to join today. Thank you so much, our own Dr. Rohit from Aurangabad. We have a very nice discussion on recurrent pterygium and limbal stage deficiency, and a very good take-home points for the case discussions put by the moderator, Dr. Shruti Madam. Thank you, Shruti Ma'am. Thank you, mentor, Dr. Mayur Kulkarni. Thank you, the case presenters, Dr. Samruddhi and Dr. Komal. And Sumit is the person behind the whole show. He is taking a lot of efforts for each PG activity. So to say thank you to Sumit is, I think, it's a smaller word. But till, thank you, Sumit, and thank you, Entod. We have a very nice PG activity today. Please be there on next Thursday again with a different topic. And thank you.
Thank you, sir. Thank you, sir.
Thank you. Yeah.
Thank you very much, sir. Thank you very much.
Thank you. Thank you. Good night.
Good night.
Thank you, everyone, and good night.